Good afternoon everyone. So today's our lecture is on pulp therapy for non-vital tooth. The contents will be what is pulpectomy, indications, contraindications of pulpectomy, single visit pulpectomy, multiple visit pulpectomy, ideal requirements of a root canal filling material, obturation techniques, commonly used obturation materials, and zinc oxide eugenol, calcium hydroxide as an obturating material, and finally coming to the apexification. So first coming to the pulpectomy. As you all know that Mathewson in 1995 he defined that pulpectomy is complete removal of the necrotic pulp from the root canals of primary teeth, filling them with an inert desorbable material so as to maintain the tooth in the dental arch. Objectives of pulpectomy are: it maintain the tooth free of infection, biomechanically cleanse and obturate the root canals, promote physiologic root resorption of the tooth, and hold the space for the erupting permanent teeth. These are the steps of pulpectomy. First of all, this is a carious tooth. Suppose there is a periapical pathology, so we gain the access to the coronal pulp through a micromotor or a aerotor handpiece. Then after that we use a root canal filling obturation root canal instruments, that is like a file, K file or a H file, to clean the canals and fill the canals with the obturation material in the end. Indications of pulpectomy are: a tooth which is previously planned for pulpotomy but it has got an uncontrolled pulpal hemorrhage, that is the pulp has gone towards irreversible pulpitis changes, indicated for any primary tooth in the absence of a permanent successor. Any deciduous tooth with severe pulpal necrosis, provided there is no radiographic contraindication, that is there should not be external or internal resorption. Primary teeth with necrotic pulp and minimum of root resorption. Pulpless primary teeth with stomas or pulpless primary teeth in hemophilics. Pulpless primary anterior teeth where speech or aesthetics are a major concern, and pulpless primary molars holding for a orthodontic appliance. As there are indications, so we can understand that there are contraindications as well. So clinical contraindications are: when there is a excessive tooth mobility, there is communication between the roof of the chamber and the furcation area, that is there is no tooth structure present and a furcation is perforated. Insufficient tooth structure is there to allow isolation of the tooth, or coronal restoration build up at the end, that is a tooth which cannot be restored should not be taken for pulpectomy. Radiographic contraindications are external root resorption, that is a tooth is showing chances of root resorption, we should not perform pulpectomy. Internal root resorption is also an contraindication. A tooth with a radicular cyst or dentigerous cyst, any kind of pathology is there associated with the tooth, so we do not recommend to do a pulpectomy. And finally, interradicular radiolucency, that is a tooth with a radiolucency in the furcation area which has got a big communication with the gingival sulcus. So pulpectomy has to be divided or done into two parts, that is either it is a single visit pulpectomy in which we do the entire procedure in the single appointment, or it is a multiple visit pulpectomy. So single visit pulpectomy indications are: large carious exposure with frank involvement of the radicular pulp but without any periapical changes, that is a tooth which has got a caries exposure of pulp but there are no periapical changes, so we can go for a single visit pulpectomy. Primary teeth with inflammation extending beyond the coronal pulp, indicated by hemorrhage from the amputated radicular stems, that is dark red, slowly oozing and uncontrolled, that is we know that when we are performing these procedures we have to do the coronal access opening. After that we remove the coronal pulp and we try to control the bleeding from the radicular pulp, that is the root canal orifices. If the bleeding is profuse, it cannot be controlled, so we have to go for a pulpectomy, and in that case we can go for a single visit pulpectomy. Multiple visit pulpectomy is recommended when there is a infection, abscess or chronic sinus, that means when there is any kind of the periapical pathology. A tooth which is non-vital, that is when the pulp has gone non-vital, we have to do it in a multiple settings. The first sitting we do the cleaning and shaping of the canals, we give a dressing, and then subsequently we go for the next appointment, we go for the obturation of the canals. A tooth with necrotic pulp and periapical involvement, as we already told, any kind of periapical changes, we have to go for a multiple visit pulpectomy. After the pulpectomy is done, that is the cleaning and shaping of the canals has been done, it needs to be filled with a ideal adequate material, that is called obturation material. So these are certain requirements of a ideal obturation material. The material should resorb as the primary tooth root resorbs. Since we know that the primary teeth they resorb and the permanent teeth come into their place. So if we fill the canals with a material which is not resorbable as per the tooth resorbs, so it can retain in the oral cavity and it delays the eruption of permanent teeth, or may lead to non-eruption of permanent teeth also. So the most important requirement of an ideal obturation material is that it should resorb as the tooth of the root resorbs. It should neither irritate the periapical tissue nor coagulate any organic remnants in the canal. If it goes periapically, it should not irritate any kind of periapical tissue. It should have a stable disinfecting power, that is, it should have be disinfecting, that is antiseptic properties. Any surplus material passes beyond the apex should be resorbed easily. We have told it in the second point that periapically it should be biocompatible. So if it goes also, it should resorb by itself. It should be inserted easily into the canal and removed also if necessary. So that is the ease of application. It should be easy to apply, and maybe if redo of procedure is to be done, then it is easy to retrieve also. It should not be soluble in water. It should not discolor the tooth. Yes. And it should be radiopaque so that we can check whether we have done a right obturation or not. If it is not to be seen on the radiograph, so how will we assess the success? And it should be harmless to the adjacent tooth gum. As we know that if it extrude also, there is a tooth gum below the primary teeth. So if it extrudes, it should resorb and it should not affect the developing permanent tooth gum. These are the certain obturation materials or techniques which are used. The aim in obturating the canals is to prevent recontamination of the canal from the apical or coronal leakage, and to isolate, neutralize any remaining pulpal tissue or bacteria which is there. That is, the material should have antiseptic properties and it should provide a proper coronal and apical seal. Endodontic pressure syringe was first developed by Greenberg, and it is used in obturation material, in obturation of root canals. This can be a mechanical syringe and it can be a tuberculin syringe as told by these authors. These are the various other methods or techniques which are used in the obturation of root canals. Like there is an incremental filling technique. There is lenticulospiral technique also, that is the root canal obturation material is taken on the lenticulospiral and it is inserted into the canal with the help of it. Amalgam plugger can also be used. Paper points can be used for obturation along with the obturation material. The plugging action with the wet cotton pellet, that is a pressure syringe again method, that the material is inserted on the orifice and then it is pushed into the canal with the help of the wet cotton pellets. And incremental filling with the reamer. Reamer can be taken, obturation material is taken onto the reamer and it is inserted into the canal, and the reamer is removed subsequently, leaving the material inside. So commonly used obturation materials which we can see in the table are like zinc oxide eugenol. Zinc oxide eugenol, we know that it comes in the form of the zinc oxide powder and eugenol oil. They are mixed and inserted into the canal. Iodoform, that is a derivative of iodine. Vitapex is a combination of calcium hydroxide, iodoform and oil additives with it. Walk-off paste, which is parachlorophenol, camphor and menthol along with it. KRI paste contains iodoform, camphor, parachlorophenol and menthol. Maisto paste, that is contains zinc oxide, iodoform, thymol, chlorophenol, camphor and lanolin. Mineral trioxide aggregate, which is tricalcium aluminate, tricalcium silicate, silica oxide, tricalcium oxide and bismuth oxide. And endoflask, that is barium sulfate, calcium hydroxide, iodoform and zinc oxide eugenol. As you can see in the table that most of the materials are either zinc oxide eugenol based or calcium hydroxide based. So coming to the most common two materials which are recommended for obturation, that is first one is zinc oxide eugenol. As you can see that Bonastri in 1837 he recommended the use of zinc oxide eugenol in dentistry. So it is the first root canal obturation material, and till date it is the ideal obturation material, considered to be the best obturation material. It is used to have anti-inflammatory and analgesic properties, but there are certain limitations. It has got slow resorption as compared to the resorption of the tooth, radicular tooth structure, irritation to the periapical tissues. If it goes beyond the apex, it irritates the periapical tissues. It can cause necrosis of bone or cementum and alter the eruption of the permanent tooth also. These are certain limitations, but still it is the considered to be the best root obturation material. The next one is calcium hydroxide. This was first introduced by Hermann for use in dentistry. The present generation calcium hydroxide had been used as a prime root canal filling material, that is either form of Metapex or Vitapex. The rate of resorption of the calcium hydroxide is slightly faster than the tooth root structure, that is the radicular tooth. But if it extrudes, there is no adverse reactions to the periapical tissues. That's why favored. Studies have reported a success rate of 80 to 90% with calcium hydroxide. Coming to the another form of pulpectomy, that is the apexification, which we generally recommend to do it in the young permanent tooth. It is defined as a method to induce the development of the root apex of the immature pulpless tooth by formation of osteocementum or bone-like tissue. What happens is that in the young permanent tooth, when the apex closure has not happened completely, and if there is a kind of periapical pulpal pathology happens, so the apex is not completely formed. As you can see in the picture, open apex is there. We cannot fill or obturate the root canal of the tooth with the gatta parcha. So we need to perform a procedure called apexification. In this, we induce the apical closure with the formation of a mineralized tissue. This mineralized tissue can be osteocementum or a bone-like tissue, and in the apical region of the non-vital tooth with an incompletely open apex. For non-vital permanent teeth with the open apex, these kind of canals are also called as the blunderbuss canals. Objective of apexification is to induce either closure of open apical third of the root canal or the formation of apical calcific barrier against which obturation can be done in future. The materials generally recommended are zinc oxide eugenol, metacrysyl acetate, tricalcium phosphate with beta tricalcium phosphate, resorbable tricalcium phosphate material, collagen, calcium hydroxide, and most newly material is mineral trioxide aggregate. These are the certain criteria for the success of the apexification, that either the apex is closed with minimum recession of the canal, that is the canal patency or the width of the canal is maintained but the apex is closed. The second is the apex is closed but no change in the root space is there. Third is radiographically we can see a calcific bridge is formed at the apex. And finally, there is no radiographic evidence of apical closure, but clinically there is a stop is felt at apex against which obturation is done. So thank you everyone for your patient hearing. If you have any questions, you can come to me. Thank you.